So we're going to move on now to decision making and prioritisation in major trauma. It's a little bit like the OTA party, okay? So you get towards the end, you could be dead, nearly dead, or the following morning might as well be dead, okay? That seems to be quite a regular event here. So Jonathan McGregor-Riley has come from Northern General in Sheffield to give us this talk. I don't do trauma anymore, which is great. Thanks, Jonathan.
Thank you for the introduction, and thank you for the invitation to come and talk to this group. I have to say, I wasn't first choice. Someone who's probably well known to many, if not all of you here, my colleague Simon Royston, was unable to come. He's on tour with the British Limb Reconstruction Group, lecturing in, I believe, Hong Kong, Singapore, and then somewhere in Australia. So he's got a little trip. Now I get to come to Blackpool. And I've seen those photographs of your conference, and I bet he's not having half the time that he would have had if he'd come here. So thanks for the invitation. So what I want to talk to you about is major trauma. I've got no gory videos, a few gory pictures. I want to start by taking us all back, which is now over 4 years, to 2012. I'm sure you all recognise the picture here of the London 2012 opening ceremony for the Olympic Games. Now, I'd swapped an on-call. If any of you ever swap a shift or an on-call, you know you're in for a hard time. And this night was no exception. So I was enjoying my early evening at home, watching the opening ceremony with my family and having a good time. The people in this vehicle were not having a good time. They had been having a good time, and it came to a sudden halt. One of the occupants of the vehicle was a 17-year-old called Whitney. She says I can talk about her, so I will. She was ejected from the vehicle. Someone died at the scene. So we know it's a serious incident. A death at the scene means this is seriously bad. And she had a number of very serious injuries. She had a pelvic fracture, and here's an X-ray which shows injury to the pelvis with fractures of the rami at the front, and there's a dislocation of the sacroiliac joint at the back. She had fractures of both femurs, one of which was an open fracture. She had a left grade 3C open tibia. We grade open fractures, as many of you know, from 1 to 3, and 3 is subdivided into A, B, and C. So this is the worst of the worst. What do I mean by that? She had an open fracture with no pulses present below the fracture. She's nearly torn her leg off. It's grossly contaminated. I think she basically was dragged through a hedge bottom as she ejected the car. So as you can see, she's got a pulseless foot. 2 hours later, she gets into hospital because of a lengthy extraction time and getting her to hospital and an initial resuscitation. And these are her parameters. She's tachycardic. She's a young girl, remember, heart rate of 110. But she's managing to maintain that blood pressure of over 100. She's conscious, she's alert, Glasgow Coma Scale of 15. And she has a lactate measured at 9. I'll come to lactate in a little while and how significant that is. It's bad, by the way. 9 is bad. So what do we do? What do we do about this myriad of major life-threatening and limb-threatening injuries? Do we do something called damage control? Or do we go for early total care? And how do we make those decisions? She's got open fractures, she's got pelvic instability, she's bleeding, she's got a pulseless foot. What's most important? How do we decide what to do? So it's all about making the right decisions and prioritising injuries in the appropriate order. First of all, of course, she has resuscitation in a resuscitation room. And that's a really old photograph. One of those guys there is now retired, and one of them is a hand surgeon. So what do? We take this person, yes it was, we take this person to theatre and we stabilise her pelvis with an external fixator to stabilise the joint. We quickly stabilise her femurs with external fixation. Why do we do that first? Because bleeding from a pelvic fracture, open femoral fractures and closed femoral fractures are what kills people. So that's what we deal with first. And a couple of hours later, her heart rate's come down and this lactate level has come back down. That now means that we can think about that pulseless, highly contaminated lower limb injury to do something about saving that limb. Because up until that point, we were trying to save this girl's life, and therefore we couldn't afford to worry about the pulseless tibial fracture. So with the use of damage control, with good resuscitation, and with what I consider to be the most important but most basic of skills that any surgeon should have, which is how to put on an external fixator, we can save people's limbs and occasionally we can save people's lives. But what we must be able to do alongside those surgical skills is prioritise, make appropriate and timely decisions, and that requires our knowledge and our experience, but it requires a whole team of people such as yourselves, who may well get involved with these patients in resus, particularly anyone who's involved in treating patients in major trauma centres. There are various models for decision making. Some are more complex than others. Here's a decision making model I found with just a simple search, which probably is useful for those that might understand it. Orthopaedic surgeons cannot work at that level. When we're dealing with major trauma, we've got to first of all recognise the problem. Now, if I had videos like Graham had that showed how this steel worker in Sheffield managed to sustain that, then it would be pretty gory. To be fair, a vaulter jumping over a vault with a closed fracture, it's just a closed break. I'm sure you'll be able to put a cast on that or a tibial gaiter, it'd be fine. That's a whole different kettle of fish. The guy on the right-hand side, he has major trauma. This causes disability, open fractures, joint injuries, and we've heard about the possibility of developing osteoarthritis down the line. So that can cause disability, but when you're multiply injured, like the guy on the right, you may not survive. So you need a very simple algorithm, and orthopaedic surgeons cannot work in anything more than 3s. Hence the open fracture classification, type 1, type 2, type 3. Someone made it more complicated with A, B and C, which isn't very good and therefore it doesn't work. What I would suggest as an algorithm for treating major trauma is really simple. And actually when you look at it, it's not 3 things, it's 2 things. It's life before limb. And that's all it comes down to. Now, my colleague Mr. Dennison, another Yorkshireman, there's his quote, there's no point having the nicest looking leg in the mortuary. What I tend to think is, if your patient's dead, then the bone is dead and we can't fix dead bone. Well, we can, but it doesn't really work. So let's just go a little bit back to basics. This is something that we'll learn when we do our ATLS trauma courses, and what happens to people. How do people die in major trauma? There are 3 phases really. The early phase, the unsurvivable injuries that happen within the early stages, and then the late phase where you succumb to multiple organ failure and sepsis. But there are these that happen within the first hour or 2 where we can get in and do something to try and preserve life. So that's where we focus our efforts in the resuscitation of major trauma. But when you look at all of those, what they mostly boil down to is bleeding, hemorrhage, and that's what we've got to try and treat. So I'll spend some time looking at how to prevent people bleeding and hemorrhaging to death. If you are hemorrhaging, if your blood pressure is less than 90, you're 7 times more likely to die. So what do? Well, we all learn ATLS. We learn how to identify, how to treat those immediately life-threatening conditions, starting with the airway and the breathing and ventilation, and then circulation and hemorrhage control. So we have a well-defined system that's utilised in just about every hospital in the Western world now. When we've done that, we've got an alive patient. The orthopaedic surgeon and the orthopaedic team then have to think about what to do about all those injured limbs. Now, this is a patient that came in one night when I was on fellowship in New Zealand a few years ago. They had a slightly different way of doing things. I stayed up all night and tried to fix all those fractures because that's what the orthopaedic surgeon does. We're great, we get in there, we fix everything, we're heroes. So early definitive care, some external fixation, some intramedullary nails and plating, that takes all night long and into the next day. In the 80s and the 90s, when people first started researching and looking at this, Larry Bone, a great name for an orthopaedic surgeon, published a study to show that if you stabilise fractures early with early treatment and early care, like I showed there, then the results are better. And he said that these patients are too sick. You can't just put them on a ward and leave them alone. We must do something operative. And the reason was that this chest x-ray shows someone who has ARDS, acute respiratory distress syndrome, or fat embolism. So it's 5 times higher if you don't stabilise fractures in the first 24 hours. So the feeling was we must get in there, we must do something. But when we started to look at the physiology of this, and one of the leading people that's looked at this is Professor Giannoudis from Leeds, another Yorkshireman, not quite a Greek, but lives in Yorkshire, honorary Yorkshireman. We started to realise that there's something going on here with the physiology, and people may actually be so poorly that we shouldn't be operating on them. When you sustain what we're calling the first hit of the trauma, you release all this stuff, cytokines, complement, coagulation, proteins, all sorts of things that are inflammatory. So you develop an inflammatory response syndrome, systemic inflammatory response syndrome. It's indistinguishable from the really poorly patient with sepsis or with pancreatitis. And balancing that is a counter response syndrome, which eventually leads to recovery and homeostasis. Now, if your patient receives a second hit, by which, I'll come to it in a second, what I mean by the second hit, that inflammatory response syndrome carries on getting worse and worse, and you don't reach that homeostasis stage of recovery, and you may well die. So we've adopted this doctrine of damage control. It began in the US Navy. It was all about saving the vessel, the ship, the submarine that is catastrophically damaged. What do you want to do? You want to prevent flooding. That's like stemming the bleeding. You want to put out the fires. That's damping down the inflammatory response. You want to maintain its structural integrity. That's like splinting fractures, to prevent loss of the vessel, death. And it's aimed to minimize the impact of that second hit. Now, the second hit might be that we don't completely resuscitate the patient at the first attempt. So inadequate resuscitation. They may be bleeding excessively and we're not preventing or stopping that ongoing bleeding. Or it may be surgery. So if you decide to do all that early total care on your patient, it's a big second hit. And that was a big second hit for this patient, who did survive, to be fair. The aim of damage control, on the other hand, is restore the normal physiology. It's all about keeping the patient alive and then think about restoring anatomy later. And we have to think about something which is termed the lethal triad. It's not quite come out right, my top triangle. There are 3 things that will kill your patient. If they don't clot, if they become acidotic, they're producing lactic acid and get acidotic, or if they get cold. So these are actually really simple things to think about in a way. So we can use these parameters to work out which patients are so poorly that they can't have lots and lots of big surgery. We can easily measure their temperature and keep them warm. We can do blood tests to see how well they clot, and we can do a simple blood gas test to see how acidotic the patient is, how much serum lactate do they have. So that's why I talked about that in that case example at the beginning. And we talk about a cutoff of about 2.5. But what we're interested in is what's happening to that lactate. Is it going up and up and up, in which case things are out of control, or is it coming down, in which case we're on top of the situation? So there are various phases. We've talked about the ATLS, primary survey, and the initial life-saving treatment. Then there's the OR phase, the American OR, where we do this damage control, which is rapid and focused surgery. Then we want to get the patient to where every trauma patient should be, on the intensive care unit, being looked after properly. And then we can reconstruct at a later date. So what does that damage control surgery consist of? Well, we want to control hemorrhage. Number one, if your patient bleeds out, they're going to die. Next thing we need to think about is decontaminating body cavities. So I can briefly talk to you a little bit about open fractures. We may need to decompress compartments, and many of you will be familiar with compartment syndromes in limbs, but patients also sustain abdominal compartment syndromes. The skull is a compartment. If your brain is swelling, it must be decompressed. We may need to stabilize the skeleton, and we'll talk briefly about external fixation. And when you've done all that, as with the case that I showed at the beginning, you may then be able to go on and revascularize. So they're the three things I want to quickly just cover in the rest of this talk as examples of how we work together. So we have a multidisciplinary team. We've got obvious elements of that team, the surgeons and the anaesthetists and the people that help those, like ODPs and physician's assistants and so on. But there are people that we don't necessarily automatically think about. On the trauma call in the major trauma centre is the radiographer, an interventional radiologist, an angiographer. You saw those early slides where we had to do angios in the middle of the night on this patient. They're all vital part of this team. But don't forget, we're going to be sending blood tests off. We want blood to transfuse. So you need a whole team of people in the labs who are part of the resuscitation team. This is our operating theatre in the Northern General in Sheffield. Theatre 11, trauma theatre, has been for many years, and it works really well as a trauma theatre. Why? Well, you can see my consultant anaesthetist colleague propping up the doorway, looking pretty cool. He always does. He's quite a cool guy. He's Phil Dobson. But he's got a really large anaesthetic room in there, so you can get everything in there and all the team that you need in there. We've got a really large theatre. We set the theatre out so that whilst I'm operating, or whoever's operating, we can see the monitors, we can see the screen, we can talk to the anaesthetist. We've got the radiographer there who knows what they're doing. It may seem obvious, but not everybody does. And this is not a case where you have someone who comes and says, I've never actually done this before, I've never screened a tibial fracture before. You need competent, experienced staff. And you need to have the patient on the right kind of table. So we use this sort of table where it's 100% radiolucent. We can run the image intensifier up and down the total length of the patient's body, top to bottom, and fix anything from head to toe. So we can even put the patient lateral if we use a beanbag mattress. So let's take this model of the pelvic fracture to think about how we might control hemorrhage. You can see here this patient's pelvis is kind of split in two. It's what my colleague calls a petrol tank suppository. Motorcyclist comes to a sudden stop, legs do this, and patients bleed. Now you can see here, our friend Whitney, she had a pelvic fracture as well, and her femur fractures. And you bleed massively from these sort of injuries. So in the first 24 hours, what do we do about pelvic fractures? We stop and control the bleeding and manage the hemorrhage. And that's primarily what it's all about. It's so important and it's so life-threatening that the British Orthopaedic Association have a whole set of standards and guidelines on how to deal with pelvic and acetabular fractures. Why are they so scary, really? Well, inside the pelvis are the organs, the bladder, rectum, uterus, sometimes, and lots of big blood vessels. And if they're torn, which they may well be, then patients can bleed massively. Mostly, bleeding is thought to be from the veins, of which there are numerous veins. Less commonly, patients bleed from arteries, but the bleeding from arterial bleeding is usually quite massive and obvious and very life-threatening. So this open book or AP compression fracture may have caused some bleeding. It's wider than the 2.5 centimetres or inch that people talk about as being significant. And it's the commonest, lateral compression injuries, which are the other type of pelvic fractures that we commonly see, are much more common. It's the bottom part of the pie chart there, lateral compression injuries. That's how that happens. You're the driver, car comes in from the side, and you suffer a lateral compression fracture. Doesn't look quite so spectacular, but when you look closely, there's a horizontal fracture at the front, and the pelvis is swung inwards, and that sharp spike of bone, if you've been out for the night and your belly's full of beer or your bladder's full of urine, that spike can perforate your bladder. You can get a bladder perforation. So beware of that. But if you get hit from the side, not only does your pelvis get damaged, but the ribs get damaged, the lungs get damaged, the liver gets damaged, the spleen gets damaged. So if you're bleeding massively, you may well be bleeding from all those other sites as well. The other type is the vertical shear fractures, often from someone who jumps from a great height. And you can see here that the right side of that patient's pelvis has been displaced significantly. So now, in the major trauma centre and in most trauma units, a patient who comes in multiply injured would go straight through a CT scan in the early stage. So we image the pelvis now before we really examine it. The days of log rolling patients and springing the pelvis to palpate and see if it's unstable have gone. We need to be getting really worried if patients are hypotensive. And it's all about making sure that if the patient's bleeding from their pelvic fracture and starting to clot that off, you don't disturb it. You don't want to roll that patient over or squeeze the pelvis and disrupt that clot. If you're hypotensive and you have a pelvic fracture and major trauma, your mortality is very high. So this means that these patients should be looked after by senior clinicians, people who are used to dealing with this. And that's why we've evolved to the major trauma system, where patients are transferred directly to a major trauma centre. We've got to replace the blood loss if they're bleeding. And what we want to give is massive amounts of blood, cryoprecipitate platelets, so that we're not just giving a couple of units of packed cells, which doesn't really clot. We're making sure that patients have exactly what they need to restore their coagulation so that you don't get into that triangle of death. We give tranexamic acid, which is something that helps stop the bleeding. We may even allow them to run at a lower blood pressure so that the blood is not forced out through those vessels that have been damaged. This is a device that I think has revolutionised the way we treat the pelvic fracture and how we stop bleeding. The pelvic binder, or the pelvic circumferential compression device. Basically, it's a big belt that gets wrapped around the middle of the pelvis. Many of you may have seen it in patients who end up in trauma and in resus, and you tighten the pelvis to stop it moving around. And any patient in whom you think there may be a pelvic fracture, certainly if they've got signs of shock, then they should have one of these. You can slide it under the patient, you don't need to roll them over. It must be placed at the level of the greater trochanters or it doesn't really work, and you tighten it up. It's as simple as that. And the idea is it's stopping the pelvis moving around, stops it jiggling. And that allows that clot to form and it means it doesn't get disturbed and broken down. So here's an example of one of those fractures where it's an open book or AP compression type fracture with a widened pelvis, and you can see those little springs at the front there are the spring-loaded clasp in the pelvic sling, and it's been tightened up there and moved down slightly to the correct position, and it's closed the gap. It's not without its problems. If you leave these binders on for too long, patients can get skin breakdown and pressure sores. And if you over-tighten it, that can be a problem, and leave it on for too long. And what we generally say is release it at 24 hours. By then, the clot's stabilised, the patient should be stable. But you've got to look at what's happening with the patient to decide that. People think there might be problems with these. Can you assess the abdomen? Can you do a laparotomy? Can you pack the pelvis if the patient's bleeding? All of this is possible with care and appropriate use of a binder. You can't over-compress the pelvis with a pelvic binder. There's never been a case of any reported injury by putting on a binder. You can only make the situation worse. Rephrase. You can only make the situation better by putting on a pelvic binder. You can't really make it worse. Some people worry you might close the pelvis and you can't then see the fracture that's there. And so if you release the binder, you probably ought to get an X-ray afterwards, which we tend to do. So in pelvic fractures, is there a role of external fixation? Well, in some fractures where the ligaments around the back are intact, you can close the pelvis at the front and put on an external fixator. That does work, and you can see how, I'll skip over that, but you can see how that can be done effectively. But in the acute setting, the binders are so good, they're so effective, that we really don't use external fixation of the pelvis anymore at all. Maybe it's useful in open fractures or if there's severe soft tissue compromise, but it may not stabilise the pelvis that well. What about the role of operating room personnel, other allied health professionals in the management of these patients? So if the patient's continuing to bleed, we may have a patient who is what we say a transient responder. So they have responded to initial resuscitation, but then they've deteriorated again. They're probably bleeding from their veins. If the patient doesn't respond at all and is still showing signs that they're bleeding, they're still tachycardic with a low blood pressure, they're probably bleeding from arteries. And here's an example of one patient who we had problems with. 21-year-old young lady managed to fall from first or second story of her student residence in early terms of university life. She was admitted with a pelvic fracture, severely shocked, had a binder applied and responded. Discussed with me over the weekend, and on day 1 the binder was released and she was fine. And on day 2, after the weekend, taken to theatre, transferred onto the operating table and developed severe, massive hemorrhage. Didn't respond at all, had a major transfusion protocol applied. The vascular radiology team were called to theatre. They came within minutes and arrived, and we used something called the RIBOA technique, which is the, I have to get this right, retrograde endoluminal balloon occlusion of the aorta. It's a bit like opening the belly, putting a clamp on the aorta without opening the belly. So you feed a catheter up the groin, into the femoral artery, up to the level of just below the kidneys. You inflate the balloon and it switches off the blood supply to the pelvis and everything below it, temporarily. And it can be used to save lives. And that's what we did. So she had this RIBOA technique applied. She then went down to the angiography suite and had embolization, where bleeding vessels were identified and embolized so they stopped bleeding. And you can see an angiogram there, and there's a big blush of bleeding in the middle there. And within 27 minutes of them arriving, we'd embolized and her blood pressure was coming back up and she was okay. And then we took her back to theatre and fixed her pelvis with an external fixator, which I use as my definitive treatment, and some screws at the back of her pelvis there. So much for bleeding. quickly moving on to open fractures. We used to say that open fractures had to be operated on within 6 hours. That's gone. We now need patients to come to the right hospital where the right people deal with them in the right time. And that might mean next day, not the same day, and not overnight. So there are various ways of describing open fractures. If you think about them like a partial traumatic amputation, which if you go back to Whitney is very much what it was, then you think about these in the right terms because they're severe limb-threatening injuries. So this guy, 43, working in the steel mill in Sheffield, we still have steel mills in Sheffield, crushed between two heavy metal weights, basically looks like he's had his leg almost shot off. What do we do for this guy? Go back to the basics, ATLS, and then we look, when we know he's going to survive, life before limb, remember, we can remove the gross contamination, wrap it up, give him some antibiotics, get some x-rays, and then take him to theatre. This is damage control. This is not putting everything back together definitively. It's about saving the limb. So get rid of all the badness, debride, stabilise it, and cover it. And that involves a team of people, plastic surgeons, vascular surgeons, radiographers, orthopaedic surgical team. That's the most important surgical instrument for debridement, a simple scalpel, and lots and lots and lots of fluid. Oh, and an X-fix. So you remove everything that's damaged. Bone, tissue, skin, steel, steel dust, swarf, and wash it all out. That's where we were. That's where we got to. We've got a gap where the bone has been removed. It's thrown in the bin because it's dead. And we stabilise it. And usually that will mean for open fractures, temporary external fixation. And then often, in our hands, definitive external fixation. So that's his X-fix. That's what it looked like. He has some plastic surgery to cover the hole. And then at some point, he has a circular frame applied. And we regrow his tibia, and it joins up. And he goes back to work. Does it work? Yes. This is a study from Leeds and from Sheffield. An old study now, but we're still using exactly the same techniques. The deep infection rate for these sort of patients is 2 in every 100. And that's comparable to most studies where patients are treated for closed fractures. And it's an order of magnitude lower than most other methods of treating open fractures. So by using damage control, by making appropriate decisions, we can treat all these significant life-threatening and limb-threatening injuries. And that's what we did for Whitney, with some initial damage control surgery and some later definitive surgery. So make the right decisions, understand the pathophysiology is what's very important, prioritise and avoid the triad of death in order to keep the patient alive. But probably most importantly, it's about having a team of people who can work together, and that's why it's important that everyone understands how these things work.